Sequencing treatments in pancreatic cancer is an interesting question. We honestly do not have a lot of options, unlike diseases like colon cancer, for example, where there's a lot of time to sequence and you can go back to salvage therapies. In pancreatic cancer, if we start with FOLFIRINOX, the second line option would be gemcitabine nab-paclitaxel per ASCO's guidelines and the perfect patient, so to speak. Again, this is not out of hard randomized controlled trial data, but based on the availability of regimens in this setting. The second line option for treatment of patients treated with gemcitabine nab-paclitaxel in the first line setting are 5-fluorouracil plus nanoliposomal irinotecan. This is supported by the Napoli study, a randomized controlled trial, so we have good data behind this option. 5-fluorouracil plus oxaliplatin per ASCO's guidelines is an acceptable alternative, although with the caveat that there were two conflicting studies, one showing support of 5-fluorouracil oxaliplatin, namely FOLFOX, and one going against it. So it is a softer recommendation per ASCO.
With all different types of cancers, one thing we learned, and we learned that it is a very important aspect of how we treat patients, is the capacity to sequence therapies. And why is this important? Because you expose more patients to more treatment over time, and we know that that is likely to improve outcomes. And outcomes, definitely survival, but also think about quality of life. I mean, those patients that get exposed to modified FOLFIRINOX, some can fly through it fine, but it's a rough regimen. And for many patients, they drop out early. There's significant toxicities. It's a tough one. Plus, it eliminates a lot of patients who are older, which is the bulk of patients who get pancreas cancer. So with the introduction of nanoliposomal irinotecan and 5-FU, we get an option that allows us to think a little bit differently about first line. Nanoliposomal irinotecan and 5-FU on the Napoli 1 study suggested an improvement in outcome versus 5-FU with survival, PFS, and even a response rate reported at least first at 16%, and with 5-FU at 1%. So we know that there is something going on there. This was in patients who failed prior gemcitabine. The problem with FOLFIRINOX is, in addition to being tough on patients, and many patients not able to continue through, it also limits our second line options. So a lot of these patients end up progressing. They don't have real good second line options. Some folks use gemcitabine nab-paclitaxel based on almost no data except some small studies here and there, retrospective analysis. But there's also the capture of toxicities. A lot of these patients have neuropathy, their bone marrows are tired, they can't really go on gemcitabine nab-paclitaxel. So we limit options. With a more rational, I think, sequencing approach, with the availability of nanoliposomal irinotecan in the second line, it allows us to think a little bit more rationally. And we go with gemcitabine nab-paclitaxel in the first line, and then in second line, nanoliposomal irinotecan plus 5-FU. So it creates now a second line option that allows us to think about toning down the treatment a little bit, allow the patients to stay on treatment longer, but think about it as a longer continuum of treatment rather than just throw the whole gauntlet at them. Now I say that works for probably 80+% of the patients. For the other, I think 10 to 20%, having a BRCA mutation or a PALB mutation or maybe that DDR, although we still need to understand what that DDR means for pancreas cancer, those are the patients that may benefit better from FOLFIRINOX for now, FOLFIRINOX rather than the other sequence. But think about it. For 80+% of your patients, they probably don't need to be exposed to FOLFIRINOX, and they would be better off going through the sequence.
Nanoliposomal irinotecan has now been FDA approved for the use of in the second line therapy of patients with pancreatic cancer, especially as a doublet with 5-fluorouracil for patients treated previously with gemcitabine-based regimens, practically gemcitabine nab-paclitaxel. A nanoliposomal irinotecan can also be used alone by itself in the second line setting if a doublet is too onerous for the patient based on functional status or comorbidities.